I'll wait for some response.
Please respond. This is our final session.
Yes, Jayashree, no. Unable to think about our own death. Anyone else? Or do you all think that you're going to live forever? All are immortal. No need to think about death. No need to talk about death. So if you have not thought about it, maybe this is the right time to start thinking about it, start talking about it. So I'm showing 4 graphs. These are all of us sitting in this session. We'll be taking one of these 4 trajectories. I don't think anyone else have any other way to go towards end of life. Either you are so lucky that you are walking on the road hit by a huge truck and having a sudden death, no suffering, nothing. You just end your life in a few minutes. The first trajectory shows a sudden death. So suddenly your performance status is high. You're fine. You're doing all your activities, and suddenly there is death. The second trajectory is more in a cancer or an advanced cancer diagnosis. So your performance status is good, and then you have some diagnosis of an advanced cancer, then your health deteriorates and then dies. The third trajectory is for organ failure like cardiac failure, renal failure, or you have a chronic lung disease. Then what happens? The general condition deteriorates. In between, you will have deterioration of your health. For example, if you take COPD, their functional status will be very low. In between, they will have more breathlessness. Their condition will be deteriorating. Then they will come back, but they will not come back to their normal, like as in before. So that is a third trajectory. The fourth trajectory is for neurological conditions like dementia or Alzheimer's. The general condition will be very low and there will be very, very slow deterioration. So there is a long period of time with very bad status of health. So today's topic is not about our patients. Today's topic is about us. All of us are going to follow one of these trajectories. So let's talk about all of us in this room. We are not talking about patients today. So then it will be easy for you to understand and to be more empathetic. So if you some at least one person responded that we have not thought about your own death. If you have not thought about it, this is the best time to contemplate your own death. If you understand that all of us are going to die, all of us are going to follow this trajectory, then you will understand the value and value of others' life, and we will know how to live meaningfully, and we'll be able to help people who are actually dying. We'll be able to help them to die as well as possible. So the question is, what should I do? So I understand there are a lot of nurses in this room. Even if you are not a nurse, even if you are not a healthcare professional, what can be done when someone is dying, someone, your loved one is dying, or you yourself is going through an end of life situation? First and foremost, the important thing in end of life care is the person being as comfortable as possible. It is not just physical comfort, it is also emotional comfort, it is also social comfort. Anyone in this group wants to die very uncomfortably, lot of pain and distress, or all of us want to die peacefully? Can I see some responses in the chat? Anyone wants to die in misery and distress, or all of you want to die peacefully? Thank you, Angela, for the response. Nazima, thank you. All of us want to die peacefully. So we have a responsibility to provide that to our patients also. I always ask, if I am taking care of my own parents who are dying, I want them to be as peaceful as possible, not just physically. They should be dying with dignity. The same principle applies to the patients that we care for. It is not different. What are the priorities while you are dying? Can someone say, type something? what would be the most important thing? Imagine that you have 1 month to live. What will be the most important thing in your life? The most important thing. You can think for a minute because it's a very important question, right? Thank you, Jayashree. Family, yes, totally agree. Anyone else? Family, spend the most of my time with loved ones. See, it is all about family, right? Fulfilling last desire, yes. And so imagine it is not about how well you did an injection, how the doctor did an MRI scan, or how the hospital was so good in terms of facilities. It is about family and friends. Most of you, a few of you have responded, for most of you, it is family and friends with God and fulfilling last desire, right? So these are the things that really matter for our patients also. When they are dying, it is not you that they may want to see. It is their family members. Now, I want to see my family members. I want my kids to be around. So until and unless we ask this question, so now I ask this question, what is most important for you in the last month of life? Now I got the response. Until and unless we ask these questions, we will not be able to understand what they want. You can't assume. Okay. Again, what are the objectives of end of life care? What should I aim for when I'm caring for a patient who is dying? Primary thing is patient and family. It is not about how good a doctor I am or how good Pallium India is providing care. It is about the patient and the family. It is very important to inform the status and goals of care. Otherwise, they will think that you're going to help the patient live forever. God, nurse, please save my father. We can't save, right? We can't postpone life forever. So it is always important to mention that this is the status of this patient and this is the goals of care. My goals of care will be to make the patient as comfortable as possible. He or she is dying. We can't postpone death. We are not hastening death, but we'll make sure that he is going to have a peaceful end. He will be pain free. He'll be distress free. It has to be informed and make them aware of signs and symptoms. They usually ask, oh, is he going to cry in pain? Is he going to be breathless? What are the symptoms? So tell them what are the symptoms that can happen when someone is dying. And usually they will ask you how long it is going to take, right? How long he is going to live, how many days more. So always tell them that there is an unpredictability of time course. We can't predict the time, but according to your experience and what you have seen in this patient, you can always say maybe few hours, days to weeks, or weeks to months. There are a lot of prognostication tools which you can go through, which will tell you an approximate time period, but it is again unpredictable. And prepare the family how to take care of unexpected events. Suppose if the patient has cirrhosis liver and he has a esophageal varices, you're expecting a bleeding. Tell the family that you are expecting a bleeding. A bleeding can happen. If it happens, what is to be done? Or you should tell the family that there will be change in the breathing pattern. There can be change Stokes breathing. What should be done if it happens? So tell them what to do if any unexpected event happens so that they will be prepared. Do they know the diagnosis and do they know the prognosis? Sometimes when the patient come here for end of life care, when we ask them, they have no clue about their diagnosis or prognosis. They think that we are going to save their life. And ask the relatives, has or she or he expressed her views about care, place of care, where do they want to be, what all interventions they want to undergo. So, have they had all these conversations? Take this information from the family members. So now everyone told that family is most important when you are dying, right? That is the most important thing that you think when you are dying, when you have limited time. So understand the patient's family. See, imagine you are in the hospital. Now I said 1 month, but the doctor or nurse is not asking you about your family. You feel bad. No, they don't know who all are there in your family. They can't help you. So always ask, understand the patient's family. Who all are there? What is their relationship? Are they in good terms? Are they there? If someone is abroad, can we connect them through a video call? So all these have to be inquired. Understand their religious beliefs. If they want to do someone told about God's grace when they are dying, understand their belief system, whether they want to have a last communion, whether they want to go to a temple, whether they want the priest to come and do some rituals. Understand their cultural and religious beliefs and try to give that when they are dying. Understand their relationship with everything and get to know what kind of person he or she is. Rather than asking how are you, how is your pain, have you eaten, or whether you had your bowel movement, start asking the most important questions. What do you want out of life? We know that there is limited time, it is days to weeks. What do you want to do now? Someone told, I want to fulfill my desires, right? There is a list. We all have a bucket list. This is the time. Patients will also have a bucket list. Until and unless we ask them, how will we know about it? Maybe it is about, okay, so we had a patient who wanted to eat ice cream. Oh, the family members told, no, no, you already have cough and breathlessness. You can't have ice cream. What is wrong in having ice cream? He doesn't have much time ahead, right? So every day we used to get him ice cream. Understand what all these desire. Maybe these are silly desires. Sometimes they may want to meet someone. Oh, I have not met my cousin. We used to play together. It's been years. So we try to bring this person or do a video call so that they can meet. What is the purpose of your life? Now you have 1 month. What do you want? How do you want to utilize this 1 month? So all these conversation or questions to be asked. So how will we know that this patient is on end of life care? How will we know? Check whether they are bed bound for more than a few weeks. Check if they are semi comatose. They are only taking sips of fluids and they are not taking tablets. Then, if they are fulfilling any of these two out of four, that means they are actively dying. They are not responding. They are bedbound, semi comatose, taking only sips, and they are not responding to anything, no longer able to take medicines. That means they might be dying. That is the entry criteria. Once you know that this patient is dying, what is to be done? Talk about it to the patients and family. Tell that the condition is this. The patient might be dying. Talk about it. Ask where do they want to give care, whether it is in home, whether it is in a hospital, whether they want to take the patient to an intensive care. All these have to be asked. This should be asked much earlier, not when someone is gasping and dying. Have these conversations much earlier so that the patient is conscious enough to talk to you. Ask what is important. So someone can someone tell me what are the common symptoms that you see in patients when they are dying? Common. You might have seen your family members or neighbors or anyone, any patients dying in hospital, right? We all have seen our maybe grandparents or neighbors. What do you see? How do they die? Any symptoms that you have seen? Anything at all? Yes. One is gasping. There are two responses gasping. Yes, breathing problem. Sweating, yes. Decrease in pulse. Very good. So you have seen some people dying at least, right? In a hospital or in your neighborhood. Skin becomes cold and clammy. Very, very correct. Drop in saturation, breathlessness. Yes, correct, Musaib. Body starts feeling very cold, especially the extremities. Very correct. So there are neurological signs. The first will be altered level of consciousness. They won't be conscious. Faint glare, correct. Yes. There will be abnormal breathing patterns. You all told that the breathing changes. Loss of swallowing. That is why they stop taking food or fluid. Frothing and protruding tongue out can happen when they have seizures, but not generally seen as a part of normal dying. It can happen when the patient has any neurological illness or seizure illness. Then you can see that. So they can't swallow. The swallow reflex is lost because the nerve is not producing signals to swallow. The breathing pattern is changed. There are a lot of secretions. Maybe Evelyn meant about secretions, not frothing. Yes, secretions will be there. Sometimes they are delirious. They will talk irrelevant things. They will see dead people. Have you noticed that? They will see dead people. They'll see their grandparents and they see, oh, they are calling me. Sometimes they see dogs or there are cockroaches everywhere. So all these confusions and delirium will be there. Loss of sphincter control. They will have incontinence. They'll start voiding their bladder and bowel without any control. What are the cardiac and renal? Someone told me that there will be decreased pulse rate. So there can be tachycardia, there can be hypotension, and a few of you told that there will be cold, clammy body, peripheral cooling. The extremities will be very cold when you touch. So there is loss of the thermal regulation from the brain. The brain is not able to do that anymore for us. So the body becomes cold. Either no urine or a lot of incontinence. So all these cardiac and renal symptoms will be there. And what are the things that we should be managing from as a medical professional? They'll be very, very weak and tired. That tiredness itself is a big problem for them. They won't take anything. They will have all these neurological and cardiac functions. Some patients will have pain. Even if they're diagnosed, they are not cancer, they are elderly patients. Maybe due to the prolonged period of lying down and maybe due to the muscle mass wasting, they will have pain. And someone told about the eyes, protruding eyes, something like that. Sometimes they lose the ability to close the eyes. So relatives will ask you very commonly, "Oh, he's not closing the eyes. Should we do something about it?" Is there any problem if they don't close their eyes? Is it okay to keep it like that? What is wrong? Any nursing perspective that you can think of, if they are not closing their eyes at all, what will happen? They keep their eyes closed, eyes open, mouth open, dry eye, correct. So eye care has to be increased. The eyes will look so dry after a few hours. Same thing with the mouth. They keep their mouth open when they are unable to breathe properly. That is, the chain stops breathing set in. They breathe through their mouth. So the tongue will be so dry and cracked. Their oral mucosa will be so dry. So the nursing care has to be changed when you see these symptoms. Rigor mortis happen when after death, right? After death, the rigor mortis happens. This is happening before when they're actively dying. Sometimes they just don't close their eyes. They keep it open and the mouth will be open. And they will be unable to move. So someone has to be there all the time to give all this care. And as I said, they won't be able to move, so it can cause pain. So it will be good to have some gentle massage or passive range of motion. Will you change the position to prevent bed sores when someone is dying? Someone is actively dying. Will you, as a nurse, will you do the position change?
Better no.
Okay. The patient might be gasping for 24 to 48 hours. Most likely. So it is okay to change the position because you have to take care of the skin behind the back, right? Even if the patient is dying, one small rash over the loss of skin can be really painful. And they might As someone said, there will be less perfusion. So it is okay to change the position, not every 2 hours, but the position change has to be there. Again, you have to assess the situation also. When the relatives are there to see the patient, or then you are suddenly in a hurry to change the position, no, you can delay it for another hour. Let them be with the patient, talk to the patient, and you can delay the position change. But they are very, very prone to having pressure ulcers. So turning is okay. Tell the relatives to give nice massage. So is there any other advantage for giving massage by the caregivers? The touch. So by the way of massage, the patient will understand that my loved one is touching. They are nearby my neck.
Yeah.
They feel really good about it. Otherwise, we can't say them, no, you keep touching your loved one. Sometimes it is culturally not acceptable, right? When someone is there, oh, I feel a little embarrassed. In our culture, in the wards, if they are in the general wards, they can't do it. So you tell them, okay, these are the pressure areas. Why don't you give some gentle massage or just give some passive movements? Apply Vaseline everywhere. So that touch element is there. So patient will understand that there are people around me. The delirium will be much, much better because he or she knows that there are loved one around me. Next thing is to understand, ask your doctors. I know that this is a group of nurses, you can't stop medication, but ask your doctor, doctor, do we need to continue the medication for cholesterol at this point of time? Do we need to continue medication for diabetes? Is it needed? Someone is dying. Why do you want to control the blood sugar at this point of time? Right? So we have to ask the question, can we stop some of the medication? Do we really need to do routine blood checks? You go prick, check if the blood sugar is okay. Why do you want to prick the patient again and again? So ask your doctor whether we can stop some medication. Again, they can't take anything orally. Can we give something rectally? Paracetamol and all available as suppositories, right? Some of the pain medications are available as suppositories. Or can we give in the subcutaneous route? So change the route of medication. So should there be any change in the nursing care? We talked about the position changing, right? It need not be every 2 hours, but there should be position change. Anything else should be changed in terms of nursing care? What about mouth care, eye care, other skin care, perineal care? Should it be changed? If so, increase or decrease? Yes, it should be changed, but what should we increase or decrease, Sister Angela?
Decrease, but not stop.
Yeah, we can't stop. Sometimes the oral care has to be increased because the oral cavity will be very, very dry. And even if they are not conscious, this dryness is very irritating. It is painful. After some time, they feel little pain in their throat, which they can't express. They'll start making noises. So every hour we tell them with the cotton, you need not do it every time. As I told, tell the family members, they'll feel happy. So dip with cotton dipped in a little bit of water. Just apply it everywhere. Maybe few drops inside, so it will keep the mouth moist. Even the eye care sometimes have to be increased because it is so dry. There will be a lot of deposits happening. So it is important to increase. Sometimes the eyes will be so closed, they will not open the eyes, and it will be very sticky, right? So eye care has to be increased. Oral care has to be increased. Perineal care, like we do it like once or twice a day, you have to continue that perineal care. Position change, yes, you can think whether if the patient is lying down comfortably, we can delay it for an hour or two, but we cannot stop. You are right, Sister Sharmila. Again, our questions can be changed or our attitude can be changed. We can ask, how is he? Our focus should not be what is the BP, what is the pulse rate. That phase is over, he's dying now. How is he feeling? Your pulse reading or your oximetric reading has nothing to do with the patient at that point, right? The patient wants to be comfortable. So think ourselves, is my patient comfortable? We will do the same when it is our parents, right? We are not bothered about how is the BP. We'll be thinking, oh, is my mother comfortable? Is he lying down comfortably? Same thing. Is the patient comfortable? Again, as I said, there should be a balance between prevention of pressure sore and comfort. If it is a few hours, the last few hours, then you may not need aggressive pressure sore management. And most of our patients are on pressure relieving mattresses. Eye care, why there should be an eye care? As I said, eye care needs to be increased because they lose their retroorbital fat pad. I don't know whether you have noticed the eye look so shrunken and dry when they are about to death. Completely changes. And it is very scary for some people. They look very different. So they lose their retroorbital fat pad. And there will be the why they are not closing, because the eyelid length, it will retract the eyelid. So they won't be able to close the eye. So it can cause dryness and pain. You can always use ophthalmic gel if you want, or some artificial tears, or normal saline, just wipe it with the normal saline. Again, should we treat pain? Yes, absolutely yes. Because they are dying, you cannot ignore pain. So, how will we know whether they are in pain? They are not telling you. How will we know?
Sound by sound, they are.
Sometimes they scream. And sometimes by the facial expression. Yes, Evelyn, correct. They'll be frowning in the forehead. Generally, frowning in the forehead is indicative of pain. Or when you're going there to give eye care or massage or turning the position, at that time they will have some noises. Their facial expression changes, they'll start slightly groaning and moaning. So then you should understand that there can be pain. Should we continue? I told stop all the medications. Should we continue pain medication? Yes. So if the patient was on 10 milligram morphine, he may not need 10 milligram. So I will not stop, but I will reduce the dose. I'll reduce the dose and see next when the pain appears. Is he comforted? The last question, would you pass a nasogastric tube for giving medicines? Stop taking medicine. He has antihypertensives, some thyroid medications. All are very important. What will you do?
No, if painkillers we can give in other routes also, no, rather than giving through the nasogastric tube.
So,
Because that will create more irritation and maybe trouble for the patient.
but have you seen patients getting nasogastric tube invariably when they are unconscious and about to die? Generally, people put in nasogastric tube, oh, because patient is not taking anything, not eating, not drinking, put in a tube, irrespective of the patient is dying or not. Or the patient is aspirating. Do you think a nasogastric tube can prevent aspiration? What about aspiration? The patient is aspirating, no? Trying to feed, he is aspirating. So the important point to remember is that nasogastric tube is not going to prevent aspiration. What about the saliva and micro secretions that they have? They will aspirate it. It is not going to prevent aspiration completely. They still have secretions in their oral cavity, still have micro aspirations, which we cannot prevent. Second thing, putting an NG tube when someone is dying is not recommended. Their body doesn't need that nutrition. It is very distressing. And Sister Evelyn is concerned about what happens when the patient is at home. You can't give, the nurse can't come every now and then to give injections, right? That is where we can use subcutaneous injections or infusions. You can teach the family members. So I have done that. I have worked in the state of Goa for a few months in a hospice there. So there we used to do teach the family caregivers how to give the we put in the subcutaneous line and send them back home, and then we tell them how to inject medications through the subcutaneous. So it is not as complicated as IV injections. You are not worried about bleeding or other embolism related complications. So subcutaneous is a very safe route which can be managed at home. We manage our patients at home with subcutaneous injections. So medications can be managed. And there will be also always fear of increased pain. when I think about my death, the only concern when I had till I came to palliative care was that, am I going to die in pain? Now I know that I will not die in pain because my friends will definitely keep me pain free. But the biggest fear was, am I going to be breathless? Will I be struggling for breath and then I'll die? Or will I be having severe pain? These are the two important symptoms that you need to focus on. As I said earlier, if there is pain, check for expression, check if there is change in facial expression when you change the position. Next is delirium. So imagine that, so this is a story which we commonly come across. This man has lived a very good life, very disciplined person, very gentle, everyone loves him. And he's in his terminal stage, became so agitated, started using words which we have not even heard from him. So we could not believe that this is the same person. He started giving bad words to the people around him, to his wife, to his daughter. What will they remember when this patient passes away? Whatever he has done in 70, 75 years, this last few days of this experience, they cannot forget. So it is very, very important. And imagine their loved one is running around, pulling all the lines, agitated. That is not the memory that you want to give to your family, their family members. That is not the memory that I want for my own loved ones. I don't want to see that way for if my parents or my partner, someone dies. That is not the memory that I want. So it is very important to manage delirium. It is very, very distressing. It is important to detect delirium earlier and prevent. If they have undetected delirium earlier, it is highly possible that they will have a lot of distress when they are dying. So treat it as early as possible. Exclude possible contributory factors. It can be due to urinary retention. It can be due to constipation. When your doctor decides, okay, this patient is anyway dying, it is okay not to have bowel opening. Right? Anyway, he is not taking anything. So it is okay not to have bowel opening. This can cause delirium. So if you can change this, give attention to that. As I said, pain-free, not agitated, breathing trouble, no nausea, vomiting, no breathlessness, no maturation difficulty. These are the primary objectives that we should keep in our mind. So, do you think the patients can hear when they are dying? Can they hear? Can we talk to them? Is there any point in talking to them? Yes. So, hearing is one of the last sensation that people lose. So if when our nurses go to check or change the position or to check the skin, check the eye, they keep asking for consent. Here we are here. I am so and so. I am here to change your position. We will not cause any pain. Let me know if there is any discomfort. We are gently going to turn you. So then the relatives ask, why are you talking to the patient? He is unconscious for so many days. But it is important, talk to the patient, they can hear you. That is why, I don't know, in olden days when someone is dying, we chant, right? In Hindu practices, we sit near the patient and chant. And I'm sure that is there in every religion. Why are we chanting? Why are we doing the prayers? Because the patient can hear. Maybe they can hear us, but they become confused. I think when they hear us, they become more confident that there are people around me. Generally, they feel comfortable. When they are agitated, I've seen when their loved one go to their near ear and say, it is okay, everything is fine, we are all here. Sometimes people sing, sometimes people give prayers, settle down. And it is important not to have the cross consultations inside the room because the patient can hear. You will be telling the relative, oh, things are really bad. I think he is dying. You can talk about it outside the room because the patient is actually listening to you. So tell the family to talk to the patient as normal. Tell if they want to have some religious rites facilitated. If they have children or grandchildren, Bring them and tell children to talk to them. They will really understand. You can see the change in their facial expression also. Again, we talked about the nasogastric tube, we talked about feeding and giving injections, stopping medications. How will we decide which is best for the patient? These are the 4 principles of medical ethics. The most important one is patient's autonomy. What does the patient wants? The patient's decision are supreme. Family comes next. We are not treating the family. We are not feeding the patient for the family members. We want to feed the patient for the patient, right? So, patient's autonomy. What does the patient want? So, how will we know what the patient wants? We have to start this conversation much earlier. A patient with end stage kidney disease, end stage cardiac disease, don't wait for him to become unconscious to start end of life care. It should be started much earlier. Ask what they want. If this happens, if you are going to be unconscious, where do you want to be cared? Ask the questions. So, patient's autonomy, beneficence is doing good. By putting in nasogastric tube, by putting in an IV medication, what is the benefit that I am going to give the patient? If I'm going to prick to check the blood sugar, what is the benefit that I'm going to give the patient? So, ask yourself. The third principle is non-maleficence. Do no harm. Am I causing any harm? Okay, my supervisor told to change the position every hour to prevent bed sores. Am I causing harm to the patient? He's still on medications for cholesterol. Am I harming the patient? So ask ourselves. The fourth principle is justice. Whether you are giving justice to that particular individual or you are trying to consider the family members also. Sometimes the patients are so adamant, I want this, I want that, the family, I want to go for an immunotherapy. Although everyone knows that he's not going to be benefited. And the family doesn't have money. Because we believe in patients' autonomy, we can't support it, right? So it has to be a distributive justice. We have to consider everyone around us. So these are the 4 ethical principles. Based on this, when it comes to putting in a rice tube, when it comes to putting in a ventilator, we have to take decision. Am I taking the right decision? Am I giving some benefit? Am I doing some harm? Or is it justified? Am I doing justice to him and his family? So, can someone tell me what is the purpose of medical treatment? Is it preserving life at all cost? Option 1. The option 2 is preserve life of reasonable quality with reasonable medical measures. What is the purpose of medical treatment? Saving life at any cost or preserving life at a reasonable quality with whatever.
Reasonable quality.
Yeah, that is one basic principle of justice. You can't save everyone's life. Sometimes we have to settle down with reasonable quality of life with whatever resources which are available. And who will decide it? The patient, if he is competent. If the patient is not competent, ask who is the surrogate. The surrogate can be usually the male member of the family, invariably across our country, but ask who is the decision maker. You might have talked to his wife about everything, but one uncle will come and say, I am the decision maker, talk to me. So ask that question first, who is the decision maker? Who is the closest one? Who is supposed to take decisions for the patient? Very, very controversial topic. It is about decreasing nutrition and fluid intake. Always the family is in distress that the patient is not eating or drinking. And the neighbors will ask you, oh, why are you not taking him to any hospital? Why are you not giving any drip? Can't you just put a drip so that the patient will feel better? And why this patient is not taking anything? It is sometimes the nausea the anorexia may be very protective. They don't want that many nutrition for their body. Their system is shutting down. Their kidneys are shutting down, the lungs are shutting down, and their digestive system is not working properly. So even if you feed, the body will be unable to process the food. And I don't know, you have seen sometimes patients will clench their teeth They can't say. So they clench their teeth so that you are not going to feed them again. So these are the signs that they don't want. But the family will be very much worried about how can I let my loved one die without any food and fluid? Can't you give a drip? What will you tell them? Will you give the drip? Will you not give the drip? And what will you tell? The family is requesting me, sister, can you just give a drip because he's not eating or drinking, not responding also. What will we tell?
Explain them the situation, right now situation, and tell them that let her have a peaceful end stage. Like,
But the sister, this drip, I think he's going to feel a little better if you give the drip. Give some glucose. This is a
but
very common question, no?
IV to give it is a more torturement, like for him, pain and all that thing.
Yeah. Right. Anyone else having a difference of opinion? No, there is no right or wrong answer. If you think drip has to be given, any infusion has to be given, you need to think why. How is it going to help the patient? So the family will tell, please give something. So explain them that they'll be thinking, oh, my loved one will be feeling thirsty, there will be dehydration. So dehydration can be protective when someone is dying. They don't need these many fluids. As I said, there will be shutting down of kidneys. So even if you give artificial nutrition and hydration, the kidneys cannot push it out. I don't know whether you have seen there can be loss of decreased urine output, and the patient will start having
Yes.
swelling, right?
Yes.
Edema everywhere, pedal edema, facial edema, because you're pushing fluids and it is not coming out. And generally, all of your nurses, you are very much involved in post the death care, right? Have you noticed patients who die with lot of infusions? There will be lot of secretions when you give death care. Someone is dying in your family without any medical intervention, it will be easy to give death care.
Yes.
Generally, the secretions or the ears, nose, even if you don't plug it, there won't be much of a distress. But in hospitals, when they are out of ICUs, they are just swollen.
Yes.
Fluids come out through every possible orifice, right?
Yes.
Yeah. So why? Because we pump a lot of unnecessary fluids. The body is unable to process it. So explain all this to the patient's family. The dehydration is actually sometimes protective. And when they are starving, we know that if we are unable to eat lunch and dinner, your body will have some ketone bodies, right? The ketosis happens. The ketone bodies are actually protective because they will reduce pain a little bit. That's what studies say. So this is all body's natural mechanism to face death. I'm sure in people who are dying at home, we'll try to give some sips, one or few drops with a spoon. If they are not taking, that's all. But if they are in a hospital, we try to pump because the relatives asked for a drip. It's easy to give a drip than to explain it to them, right? Okay, just put a drip, then what is the harm? So explain what is there in the drip. I always say this is normal saline. This is like a pinch of salt in a glass of water. What benefit you're thinking this is going to give your loved one? It is just salt water. What else? And dehydration, if you think the patient is dehydrated and in distress, we can always think about subcutaneous infusions because that will be absorbed very slowly. They will not just plump up with lot of fluids. What about dry mouth? I'm sure you might have heard a little bit about the wound care, mouth care, etc. So we give, you can make this mouthwash with saline and a small pinch of baking soda, very small pinch of salt and very small pinch of like a mustard seed, that much. We can create that mouthwash. We can give every 1 hour. We tell the caregivers to just wipe the mouth or few drops. Lips will be very dry and cracked, so apply Vaseline. You can always tell them to apply some ghee or honey also because ghee is something which is homemade. You don't have to go and buy Vaseline. And ghee is pleasant taste also, even if they swallow, go inside, no problem. So either ghee or Vaseline or whatever is available, protect the lips and the nasal openings, because that will be very, very dry. So, have you ever heard a lot of noisy breathing? You mentioned about gasping and everything in the beginning. So, have you heard about the gurgling sound when someone is dying? Lot of noise.
Yes.
Anyone else? Big noise. Everyone in the house will hear this. And when the neighbors come, they'll like, oh, I think there are a lot of sputum in the chest. Why are you not taking this patient to hospital? So, what is it called generally? We call it death rattle. It's like a
Rattle sound.
rattling, yeah, rattling sound. Yeah, correct, Veena. Rattle, yes. And what can be done about it? Suctioning.
Mm,
But in hospitals, you do suctioning, right? The moment you hear this sound, you go with the suction machine.
Positioning may be
Yeah,
good position to the patient.
yeah. Positioning is the right answer to that distress. And why is it happening? Because they are unable to swallow. There are a lot of saliva and post pharyngeal secretions. They are lying down like this. Everything will be so. Imagine you have a glass of water. Okay, you put a straw into it and blow. What happens? There is gurgle sound you will hear, right? Gurgling sound. Because when the air passes through the straw, there is a sound. The same thing happens when someone is dying. Lot of secretions will be pooled in the throat, and when they breathe through the mouth, the air is passing through the fluids. That creates the noise. It is not sputum or chest infection or this or that. It is simply the secretions which is pooled behind the throat because they are not swallowing, and when they breathe, the air passes through the secretion. It will cause a lot of noise. So, as Nazima said and others said, change the position, side lying position. You can see immediately it will reduce. Still, if it is not reducing, if you want to do some, think about some medication, then glycopyrrolate, injection glycopyrrolate is something that we can think of. You can give it either subcutaneously, you can give zero point 0.1 milligram, that is 100 microgram, or you can give it as oral. The same ampule, you break the ampule and give the liquid under the tongue, sublingual. So if you are in a home setting, if you don't want to prick the patient unnecessarily, break the ampule and give the medication sublingually. It will start acting. You can go up to 1600 microgram. Generally, it will subside in 0.2 milligram, 200 microgram. And from the beginning, you are telling that when someone is dying, there will be changes in respiration. And people are very scared about suffocation and dying. So it is important to talk to the family members, consider opioids. You had a session on respiratory symptoms. You might have heard that opioids can be used for breathlessness. If you think the patient is in lot of distress, breathlessness, give small dose of morphine. It will reduce the breathlessness. Again, people will keep asking you for oxygen. Oxygen is not helpful in this situation. The lungs are unable to process it. The lungs will not be able to take it. It can cause dryness in the mouth and the throat and the nose. Oxygen will not prolong or help the patient because when someone is dying naturally, do you think everyone will die with 100% oxygen saturation? Absolutely normal sodium, potassium, calcium, and everything? No. It will reduce. When someone is dying, the saturation will invariably reduce. Until and unless they are hit by a bus, no one can die in 100% oxygen saturation. So, don't look for the saturation when someone is dying. Look at the patient instead. Look whether he is gasping. Look whether opioids are working. Oxygen is not going to help at this point. When someone is dying, there are a lot of evidence telling that oxygen is not going to be helpful. So, again, we can give two roads to death. We, as medical professionals, we have to choose whether they want to take the usual road or the difficult road. Whether you want them to be agitated, sleep, the jerks and hallucinations, or you want them to be comfortable. We are supposed to choose this. And as I said, encourage the family to talk, and hearing is the last sensation that they will lose. They may not be able to process and tell you the answers for it. And if they are someone who enjoy music, put an earphone, they can listen to the music. And as I said, create familiar environment, bring grandchildren, let them talk to the patient, include them in the conversation. Hey, what do you think about it? They may not be answering, but it is good to ask those questions. And sometimes they might be waiting for family members to accept it. Many a times, I don't know whether you have noticed, the people will be in, some patients will be in end of life care for many days. Then there will be one cousin or brother or sister who will visit. Within an hour, they will die. So these are, they say it is because that they are waiting for the permission to die. So it is important for us or as family members to accept that, okay, this patient is going to die. No point in holding on to it. And family members need your help to accept that fact. And sometimes I still remember there was one patient who has not talked to his brother for 25 years. And he expressed his wish that it still bothers me that I have not talked to him. And then he became unconscious and he was on end of life care. So we called this brother and told that this is the condition, can you come? He was from a very far place. And he came, he sat with the patient, and patient was unconscious, but he told, no, there is nothing wrong. I still love you. It was okay. There is no hard feelings between us, all these things. And he died within an hour. So it is very important to help them to do, if there is some unfinished business, forgiving, asking for forgiveness, if there is anything like that. We have to facilitate it. I'm not reading this, but when you get this presentation, or you can use the website of PalMed, lot of information on how to manage all the symptoms. They have given the doses, what medication, how to give. All these are given as a one card. So everything is there in this particular one card. So remember, everyone remembers the care during the last hours of living more than any other time. If you are given a good care, they will always remember you. So when I started working in palliative care initial years, what kept me going was that even after the patient dies, the family members come, after years, they come and give hugs to you, telling that you still remember how my loved one was taken care of. You kept him pain free. You are so good to him. They still remember. So if you want to be that nurse who everyone remembers even after the patient dies, then we have to take care of the above aspects. Always, we tend to forget about children. Children have a lot of questions. Why my father is dying? Did I do something wrong? Or why my grandmother is going? We always say they are going to heaven. God has taken them. Then generally kids feel, okay, God is someone who takes loved ones away. So it is very important to explain certain things to them. They will have a lot of questions. So I started talking to my kids about death and dying, and I took them to places where people die when they were 6, 7 years old. There are a lot of questions, but we don't use, okay, God has taken them away, or they are in the stars. No, kids don't want, they want practical answers like why they are dying and what is happening. So explain the process to children, don't ignore them. And we might have heard a lot about euthanasia, mercy killing, and all. Withdrawal of artificial life support when someone is on ventilator or anything is not euthanasia. Euthanasia means you are injecting some medication with an intention to kill someone. Your intention is not killing anyone. You are helping the patient by withdrawing unnecessary intervention. So it is not euthanasia. Understand that for our own clarity. And there are a lot of documents if you are interested to read, including the Supreme Court judgment 2023, and even in 2024, there are a lot of. And this is something which is Advanced Medical Directive or Living Will. If you log into Pallium India's website, you will get the document. If you want to write the living will, like we can plan what do you want to have when you are dying. It is a very simple process, and keep it along with your medical records. Talk to your family members that I have kept my living will about my treatment and this is what I want when I am dying. You get the document in the Pallium India's website, and you will have guide helping you how to fill in what all to be done. That is also given in the same page. So if someone is interested to have the advanced medical directive, this is please refer to it. So with that, I'll end my presentation. I'm happy to take any questions. Are there any questions?
If you need any further clarification, please feel free to ask to the faculty. Please. No one has any doubts? Is that sure? Okay, today we don't have any case to present. So as this is the final session, we love to hear from you. Firstly, let me share my experience with you people. You people were very cooperative. This is my first group of participants, I think. So I don't have any single incident of something untoward to remember. You people were very cooperative, very nice to us. Fortunately, we have Dr. Sreedevi with us today. She is heading the education department at Pallium. So it is the time for you to speak out your experiences. Good, whether it's good or bad, it doesn't matter. Please feel free to open up and unmute yourself and please share your experiences. Veronica?
Hello. Hi.
Tell us, Renuka.
Yeah. I'm Renuka Bhosle, and I work as a business manager in a company, Ostra Health, and I'm from nursing fraternity. I I have around 20 years of experience. And for this session, I would like to say this was a course which I have just joined simply understanding what exactly palliative care is, because I don't have much experience of clinical. I'm more of in academic orientation. So these sessions, I have seen that the sessions were quite good in terms of understanding the clinical scenario of the patients in palliative care. Theoretical, we all can understand, but when it comes to clinical part, more of the nurses doesn't have skills to use it and to present it when you come to the floor. So this session has provided me insight for understanding how to take care of the patient when you are working exactly with the patient. Theory, all of you can read from the books. About the speakers, I'll say uh, uh, they were excellent presenting their content. About Arya, I'll say, as Arya said right now, that she has not got any bad experience with anyone. Thank you, Arya, for being very positive. It's not that you have not got kind. I'll say I'll appreciate. She is the best coordinator for this session, and I think the management should provide her the opportunities further to manage further. So for all the teachers, all the trainers, all the speakers, coordinators, and especially Arya. Thank you for arranging the session for all of us, and we have learned really good management of palliative care patients. Thank you.
Thank you, Renuka, for your kind words.
Thank you, Renuka.
If there is anything that you want us to improve, please let us know, anyone from the group.
Others, please open up.
Hello, ma'am. This is Sharmila here.
Yes, yes, please.
Ma'am, actually, sorry to say that most of the sessions I have missed, but last 2 or 3 sessions I have, continuously. Yesterday's, I think, and today's, but it was very good, which I missed. Today, I'm feeling that I missed a chance of hearing so much, so knowledgeable and so educative part of that, your palliative care. But only thing that the thing what has happened when we are on duties and all. We are busy with the patient and we forget the time of this session and all sometimes. Most of the time that was my decision that I was on duty. I knew that it was there and suddenly the patient came and I went there and I lost the sessions most of the time. But still it was very nice. Yesterday's also tutor lecturer was very good enough and very nice and today's also. Thank you, doctor. Thank you so much. And thank you, Arya.
Thank you, Sharmila. Thank you. We understand your hecticness. Others, please. Shivani, I think you have something to say. Veronica, you have anything to say? Thank you, Angela. Thank you. Musaib Musta, where is our trio? Mathop, Lipi. Okay, then I think there is no more further opinions from your side. So we are ending the session. Anyway, we will be in touch with each other for a few more days because regarding assignments and all. As I said earlier, it was a very nice experience for me. Thank you all. Thank you. I'm sure that you all will progress in palliative care. You will be excellent in when it comes to the field experience and all. You will all be a perfect persons to for the patients. As per the patient's experience, you are going to rate yourself, I think. So thanks for all the cooperation, all the means I have been getting very good responses from your side when I am reminding for each and everything, when I was reminding for each and everything. So I'm thanking all of you. I think Dachin is coming here at Pallium for the clinical experience to practice palliative care. If you people want to come here, you can contact me or Sister Sheba, our facilitator. So welcome and thank you for everything. Thank you.